integrate CBME into the MERC curriculum. Brief introduction. The Government of India, 2019 August, if I am not wrong, introduced a very important curriculum, a curriculum known as Competency Based Medical Education curriculum. What is CBME? CBME, that is Competency Based Medical Education, is a very well-known educational strategy that is widely prevalent in the United States, United Kingdom, and other Western nations. To put it, let us not go into technicalities. I will try to put it as simply as possible. This curriculum, the aim of this curriculum is to ensure that the medical student does not become a memory master. That means he or she does not just end up memorizing all the knowledge. Instead, the curriculum aims to identify certain or a lot of important areas that are mandatory and essential for the student to understand, to thoroughly understand, to be able to assimilate, and more importantly, to be able to apply it effectively in the patient-based clinical scenario when he or she enters the clinical arena. This is the philosophy. Apart from this, it also aims at ensuring that the student acquires a certain amount of practical skills which have been defined or which have been identified as mandatory and compulsory. Proficiency in certain skills, physical skills, technical skills, before he or she completes that particular academic year or that particular segment of education before going into the next phase. This crudely sums up CBME. Now, coming to technicality, a lot of material is found on CBME. The government has defined these four broad segments which are there, which are displayed on your screen. Every subject, beginning from anatomy to radiology, will require the student to inculcate four essential requirements. 1. Competence. 2. Knowledge. 3. Skill. And 4th, integration. Now, the policy makers have created these four important subsets for every subject. So, as is quite clear, the first three segments are very clear. Every student in every subject, anatomy, physiology, biochemistry, pathology, medicine, surgery, has to acquire a predetermined level of competence. There is no compromise. 1. Second, some prescribed amount of knowledge has to be inculcated into the student. The student, vice versa, student also has to make whatever effort that is necessary to imbibe the knowledge into himself or herself. Point number 2. Point number 3, skill. This can be understood by the viewers. Certain areas, let us say simple BP measurement, temperature measurement, hearing of the lung sounds, hearing of the heart sounds, examining the abdomen. I'm just giving you very simple examples. So, certain skills have been identified. These are mandatory. These are compulsory. It cannot be the case that the student can go over to the next phase of education without learning this. It cannot be the case that he or she has learnt everything about blood pressure but doesn't know how to measure the blood pressure. No, that is not allowed. So, competency means efficiency, ability. Competency based medical education. This is what is the meaning of. These have to be applied. The student has to get them ready to apply it into the clinical arena. So, this is the crude philosophy. The last part, namely integration. This I will take 1 minute to explain. With due respect to the policymakers, we will find some complicated terms such as vertical integration, horizontal integration. What they mean is very simple. It is nothing but the synchronous teaching of medical education, STME, what I spoke some time ago. That is what it means. That means to say that when we speak of heart anatomy, right now we are all familiar. Just some time ago, I spoke to you about what is happening presently. Heart anatomy in the morning, kidney physiology in the afternoon, something else tomorrow, some other unconnected system. There is no correlation. CBME aims to integrate. Same way, heart anatomy, heart physiology, heart biochemistry, and community diseases related to the heart. Brain anatomy, brain physiology, biochemistry with respect to the brain, and diseases of the brain that we commonly see in the community, preventable and social medicine. So, at a stretch, all these need to be taught so that a comprehensive, clean, clear-cut, no confusion knowledge is developed by the student. Extrapolating this, taking this forward, same heart pathology, heart pharmacology. I'm sorry, there's no word as heart pharmacology, but pharmacology with respect to treatment of heart disease. That's what I mean to say. For simplicity, I just use that word. So, beginning from anatomy of the heart up till treatment of drugs used in heart diseases, at a stretch, uninterruptedly, if a particular teaching capsule is developed, then it will result in a very non-confused presentation of the subject to the student, so that the student will come out with a complete knowledge from beginning till end. Last but not the least, CBME as a part of integration also moots, also encourages, promotes, proposes the idea of bringing in the clinical teachers from the hospital side into this program. That means cardiac anatomy is over, drugs used in the treatment of cardiac disease is over. Up till now it is over. First year and second year have been integrated. This is what is meaning of integration, horizontal, vertical. They have been integrated in a linear fashion. After learning, what is the next logical step? A cardiologist or an MD internal medicine from the hospital side must be called. So, he or she will, in continuity, in sequence, in an unbroken, uninterrupted chain of teaching, will speak about the diseases of the heart right in the first year itself. So, the student would be aptly exposed even to the clinical hospital scenario, theoretically. So, cases will be discussed by the medicine professor or whatever it is, medicine, cardiology, whatever it is. And as when required, let us say they are talking about thyroid. So, anatomy of thyroid, physiology of thyroid, biochemistry of thyroid, pathology of thyroid, medical diseases with respect to thyroid, surgical diseases with respect to thyroid, and what are the various surgeries that are performed to address the thyroid swellings. So, anatomy to surgery, start to finish, everything will be integrated in the form of one teaching module. This is what is the fourth important part of CBME. Gain knowledge, gain competence, acquire physical skill, and lastly, integrate the subjects together. Instead of teaching one anatomy here and then the thing, and then 1 year later somebody comes and says about pathological disease of the heart. By the time heart, everything would have been forgotten, lungs would have been forgotten, kidney would have been forgotten, and then suddenly somebody says you go to the hospital, professor of kidney medicine is going to take a class. Neither will they remember, nor can they recollect, nor can they recall, nor can they relate, nor can they assimilate, nor can they associate. Nothing will be possible. In order to ensure that this does not happen, this is what is the meaning of the fourth factor, that the fourth proposal, that is integration. So, I think I have very clearly, we have put across, we have understood what are the 4 philosophies of CBME. Now, before we answer the question, how does MERC plan to integrate CBME into the 11th and 12th and preclinical and paraclinical curriculum? We have to first know the ground reality about CBME. That means to say, what is happening to CBME today in reality in the medical college, in the undergraduate MBBS program? This we have to understand. You see, what was just now spoken, what was just now presented about all the subjects being taught in a sequence uninterrupted, this I would like to call it as ideal CBME. That means this is supposed to be there, ideal. Theoretically, this is how it's supposed to happen. But having spoken to enough number of students and teachers all across the nation, without hurting anybody's sentiments, I would like to unequivocally say that today this is not happening in any or most of the medical colleges across the country. There is no implementation of an ideal CBME program, perhaps barring a few medical colleges, which can be counted on our fingertips. Why? In other words, what do I mean by this statement? I mean to say that today thyroid anatomy is being taught. Tomorrow it is not happening that physiology is being taught back to back. Let us say anatomy, physiology, biochemistry have been taught. Immediately following that, in a perfect sequence, pathology of thyroid diseases and pharmacology of thyroid drugs, it is not happening. It is not happening. The sequencing is not happening. That is what I mean to say. Chalo, let us assume that up till the second year subjects, they have been so-called integrated or whatever it is, alignment, whatever they want to call. The clinical medicine professor is not going to come, is not able to come, not that he or she does not want to come, is not able to come exactly when you want. Liver diseases have been explained, jaundice has been explained, medical jaundice, surgical jaundice, physiology of liver, biochemistry of liver, pathology of liver, microbiological bacteria which affect the liver, everything have been explained. Now the gastroenterologist has to come, or the surgical gastroenterologist has to come and speak about the surgeries of liver, namely gallbladder surgery, liver surgery. That is not happening. In other words, we come to the question, what are the factors that MERC feels after having interacted with faculty, medical teachers, students across the country? What are the key factors that are preventing the successful implementation of 100% implementation of CBME in the medical MBBS curriculum? There are 4 reasons why CBME is failing at the implementational or the executive level. It's not being able to execute it. What are those 4 reasons? 1. Lack of adequate academic time. 2. Lack of strict coordination amongst the various departments at the pre, para and clinical level to ensure an uninterrupted sequenced teaching schedule of the subjects, as we had just now spoken. 3. Lack of adequate faculty. 4. Lack of uniformity of adequate patient inflow. I think it is self-explanatory. I will not go into detailed explanation, but a very small explanation I would like to give. 1, as has been often repeated in our discussion, lack of adequate time. When anatomy, physiology, biochemistry, community medicine, 3000 pages of reading material and huge amounts of knowledge, when they require time to be absorbed, to be imparted, if 1 year, discounting all the holidays, hardly 350 days or whatever it is being allotted, how can you plan? How can we even think? How can we expect that CBME would be implemented uninterruptedly? Within 1 year, anatomy, physiology, biochemistry, everything has to be completed. On top of that, pathology, pharmacology and forensic medicine, microbiology of the related systems has to be discussed. On top of that, within the time frame, medicine professor, surgery professor, obstetrics, gynecology, dermatology, all the faculty have to come and speak at that correct time, at that relevant time, within 1 year, whether it is first year or second year, whatever it may be. How is it possible? The biggest drawback of the present system is the lack of adequate time. Whereas, when we look at the MERC curriculum, 2 years for preclinical sciences and 2 years for paraclinical sciences, more than adequate time to address each system individually, diligently, leisurely and thoroughly. Every system can be taught, thoroughly teaching it, whether it is the anatomy, physiology, biochemistry. We have adequate time. I mean, it is like having a huge space. You have a huge amount of 2 years of time in 11th and 12th standard. You can work wonders with respect to your so-called vertical integration, horizontal integration. The first thing, the first reason why there is an inadequate implementation or a not so 100% implementation is because of lack of academic time, which has been slashed to 1 year first year and 1 year second year. Lack of strict coordination, that is what is the second factor. You see, we have to understand that there has to be a highly dedicated program coordinator for this. Yes, medical education restructuring curriculum, without prolonging too much of discussion, let us come directly to the point. In order to successfully implement this program, MERC strongly promotes or moots the idea of having a program coordinator for every medical college, or for the God willing, if it happens, for every college of pre-medical sciences. These program coordinators, having adequate time at their disposal, they would be able to create a timetable by virtue of which, with the help of which, there will be an uninterrupted, unhindered, unobstructed teaching of, sequential teaching of medical subjects, of the organ systems. The most important thing is the appointment or the establishment of a full-time program coordinator. In the West also, you have these academic program coordinators who ensure that things are very well put into place in other segments, of course. So, the availability of a program coordinator for the uninterrupted execution or implementation of CBME is of paramount importance if CBME has to be implemented 100%. This is what MERC feels.
Lack of adequate number of faculty. I'll put it across in a practical manner. At 8 a.m. in the morning, if there is a class that needs to be taken on surgical diseases of the liver for the students, whether they are first MBBS, second MBBS, third, whatever they may be, whoever they may be, the surgical faculty or the teachers in the department of surgery, if there are many surgeons in the department, then one of them can come and take a class at 8 o'clock to 9 o'clock, whatever it is. But that is exactly where the problem is. If there is one professor and one assistant professor in the unit, at 8 a.m., compulsorily, mandatorily, they have to be in the operation theatre. Patient will be wheeled in at 7:30. By 8 o'clock, patient will be on the table. Surgeon has to be there when the patient is being anesthetized. That is, when the patient is being given anesthesia. No compromise. It is not the case that phone from somewhere and say, ask the anesthetist to go ahead and anesthetize. No, all those things won't work. They have to be there. It is a moral responsibility, it's a technical responsibility, it's a legal responsibility. It is teamwork. This being the case, if one of them is in the theatre, the other person will be taking rounds in the ICU, in the ITU. They'll be going through the important cases, investigations, whether they have been attended to or not. They will have to make the necessary changes with regards to inspect all the patients, previous surgeons, previous patients who are there still in the theatre, patients on ventilator. All these things have to be seen. If both of them are there, only two of them are there, how can one of them go and take class leisurely for students from 8 o'clock to 9 o'clock? Not only this, let us assume that there are 3 surgeons in each unit, let us say. Then the question may be asked, one of them can come and take. There will be 2 cases that will be posted simultaneously. 2 surgeons have to start. So, no matter what way we look at it, another question will be asked to me. Forget surgical faculty, what about medical faculty? Let us say medical diseases of the liver. Medicine faculty have to come and take the cases at 8 o'clock. Why can't they come and take it 8 o'clock? They are not able to come. Why? Huge OPD loads, MICU, medical ICU rounds, medical ITU rounds. One of them have to go to OPD. Postgraduate presentations start at 8 o'clock, 7:30, 8 o'clock, and they go on till 9 o'clock. Immediately after 9 o'clock, there will be rounds. Admitted patients have to be seen, plans have to be drawn, investigations have to be followed. So, the lack of adequate faculty is a very, very important and a common problem, because of which the CBME curriculum, full-throated CBME curriculum implementation is not happening. Having said that, I will definitely say that the CBME curriculum somehow or the other, the medical colleges are by roping in the postgraduates. The postgraduates who are there, they are coming and teaching. And also, last but not the least, as I said, it is not the case that every topic, blood dyscrasias, blood and hematopoietic system, anatomy, physiology, biochemistry, pathology, pharmacology, and medical faculty come and take this thing in a sequence. No, that is not happening. Lack of adequate faculty. MERC suggests the appointment of a full-time internal medicine post-MD teaching faculty 9 to 4. So once there is a 9 to 4 readily available internal medicine consultant in the form of a teaching faculty, 70% of the problem will be solved. So, as and when the pre and the paraclinical portion, the subjects portion is completed, the internal medicine faculty will come and complete the clinical part of it, the internal medicine part of the particular organ system, the diseases that are associated with that particular system. MERC also moots or proposes the appointment of a surgical faculty, maybe not full-time, but ably aided by the program coordinator. There has to be a surgical faculty, an obstetrics and gynecology faculty, and an orthopedic faculty. Faculty meaning they can be any subjects. They can be from the private sector. They can be all we need is people to teach. It is not that where you are from, what is your degree, what is your qualification. Those things are irrelevant. We need to have qualified internal medicine, general surgery, orthopedics, and obstetrics and gynecology, which being these are the main subjects. MERC, in the setting of a preclinical and paraclinical, that is pre-medical college environment, where you do not have, maybe you do not have necessarily a hospital attached to it, if it belongs to the honor of that setup where it is not inside the premises of an existing medical college, then MERC offers this solution to offset or to beat this problem of lack of adequate faculty. What is that? Full-time 9 to 4 internal medicine consultant who is devoted to teaching. 1. 2. Appointment of or making sure that guest faculty, general surgery, orthopedics and obstetrics and gynecology, these being the major 3 disciplines, these should be made available to the College of Pre-Medical Sciences. This is how we offset this particular problem. And last but not the least, lack of uniform patient inflow. I don't think elaborate explanation is required. There are high volume hospitals and there are low volume hospitals. So where there is a disparity, where there is a uniform lack of patient inflow, we cannot expect a full implementation or a 100% implementation of the CBME curriculum, simply because there are not adequate patients. You have 100 students. A patient comes with a thyroid swelling, or let us say a stomach swelling. Can you expect 100 students to go on pressing his stomach or her stomach? Patient will not allow. Patient will not allow. We as the faculty, the patient would come and tell us, sir, every day 20, 30 students are coming and going on pressing my stomach. I cannot take this. I cannot tolerate this. Please put it. So we put a board, not to be examined. Now here, naturally, the first question, biggest question that viewers would ask is, MERC is proposing the creation of pre and paraclinical sciences with together what will be known as the College of Pre-Medical Sciences, which offers a 4 years pre-medical course, an integrated course. Fine. But this would not necessarily be attached to a hospital. This being the case, there may still not be, whether they are attached to a hospital or whether they are not attached to a hospital, whatever it may be. How does MERC aim to offer a solution to 2 things at the same time? What are those 2 things? 1, there is lack of uniformity of patient inflow, lack of adequacy of patient inflow, and there has to be a uniform education level or a standard all across the nation. This is one of the biggest problems the nation is facing. There is no uniformity of standard of education. How do we tackle both these or all these 3 problems at the same time? The solution that MERC proposes is as follows, that will be displayed on your screen. Clinical teaching and patient availability in a non-hospital pre-medical college environment, how to implement this. In today's world of ever-advancing sciences, especially in the world of digital communication, internet, web-based teaching, virtual tools, teaching clinical medicine has become a routine process rather than an insurmountable problem. One statement would suffice. Visit the internet and you will see an endless array of teaching techniques that are so exhaustive and so detailed and so beautifully they have been explained that an elaborate explanation from my end would be unnecessary. Almost every undergraduate and postgraduate and super specialty case presentation can be viewed, and these case presentations have been excellently crafted with senior faculty from all specialties and super specialties conducting these teaching sessions. I have nothing but praise and admiration for these excellent teachers of clinical medicine and their commendable efforts, their valuable time and efforts that they have spent towards making and creating these patient-based live case presentation videos. This being the case, let me briefly put across the stages through which MERC aims to bring about clinical teaching into the College of Pre-Medical Sciences, which is on your screen. The first thing is to create a strong theory base. The key to success in clinical medicine: patient evaluation, analysis, diagnosis, differential diagnosis, complication of the disease, different modalities of presentation of the disease in a given patient, general and specific investigations, Final diagnosis, treat. Second, physical examination. Art of physical examination would be practiced and demonstrated with the aid of demonstration videos. So first is theoretical. Second is physical examination of a human being. Third, slides, clinical images depicting diseases of each organ system. Example, thyroid swelling, parotid, oral cancers, breast cancers, mass abdomen, etc. Physical models, videos of topic discussion, case presentation videos with actual patient, including history taking, physical examination, and investigations. Conducting live case presentation sessions in the college by consultants with the actual patient right in front of the students. Patient, of course, needless to say, having been brought by formal consent. Tri-monthly hospital visits by the students throughout the year. Community outreach program. We will elaborate this later. Students' self-learning initiative by attending outpatient departments of private consultants in clinics and hospitals/nursing homes as observers after college hours and learning the art of diagnosis and treatment. So, this in brief is how MERC aims to bring about the execution, the implementation of the the CBME curriculum, of especially the clinical teaching implementation in a pre-medical college environment, 4-year PMIC. After having given a broad outline, now we'll gradually come to a specific timetable, because the viewers naturally would be interested in a specific timetable breakdown. Student comes to the College of Pre-Medical Sciences, whether it is preclinical or paramedical. They are there at 9 o'clock a.m. What is your timetable? That is a question they are going to ask. So, MERC herewith proposes the following timetable. 9 o'clock to 4 o'clock. This is where the organ system based synchronous teaching of medical subjects would be implemented. 4 to 5 p.m., as you see on your screens, will be the golden hour of clinical teaching, practical skill training, and minor therapeutic skills in the MERC curriculum. Now, the clinical and practical skill sessions, training sessions from 4 to 5 p.m. every day for 4 years, 2 years of preclinical and 2 years of paraclinical. Every day, post-theory classes as per the timetable depicted in the subsequent section. The last hour, namely 4 to 5 in the academic curriculum, will be dedicated to clinical teaching, practical skill training, and minor therapeutic session. This is how the logical and scientific foundation of clinical medicine is created. We are going to have a chart presented in front of you, wherein the clinical teaching, when the students joins the 11th standard, that is preclinical sciences, 4 to 5 p.m. every day, the first 1 or 2 months will be dedicated to the approach to medical case history taking, surgical case history, OBG case history, and orthopedic case history taking. This would be followed by the art of physical examination of a patient with reference to all the organ systems. This would be followed by seminars of individual common diseases affecting each of the organ system. This would be followed by case presentations of individual diseases affecting the organ system, whose anatomy, physiology, biochemistry, and community medicines are being taught. Medical cases, example, anemia of unknown origin, fever of unknown origin, the entire chart is in front of you. Surgical cases, right from a small swelling on the skull, namely the sebaceous cyst of the skull, up to the foot, all the diseases that are going to be taught, they are going to be discussed. In brief, it has been shown on the chart. Similarly, the same thing will be extrapolated to the obstetrics and gynecology and the orthopedics. MERC aims to bring in certain basic skills at an early stage which would prepare the pre-medical student for the MBBS course in an accelerated manner that hitherto has not been seen in the MBBS curriculum. What do I mean by practical skills? I am not referring to the patient-related physical examination skills. At the end of 2 years, the student would have gained proficiency in performing the following special procedures, which would also help in promoting community service. This entire list is there in front of your screen. I would request the viewers to go through this. Example, central nervous system, early detection of Parkinson's disease, cerebellar degenerative diseases. Fundoscopy, examination of the eye. Optometry, the usual when we go to the eye specialist to see whether the vision is intact or not. External ear examination, nasal examination, oral cavity examination, indirect laryngoscopy, examination of the larynx, the voice box, audiometry, that is hearing test and interpretation of these results. Respiratory system, we are coming down sequentially. Respiratory system, pulmonary function tests, how to perform, how to interpret the tests. Gastrointestinal system, performing and interpretation of abdominal and pelvic ultrasound, including renal ultrasound. Cardiovascular system, 11th and 12th standard students would be taught how to measure blood pressure, pulse rate, pulse, various disorders of the pulse, ECG, echocardiography, and treadmill test or the stress test. Evaluation of bone and joint disorders, ability to interpret X-rays of all the simple X-rays of all organ systems, and introduction to CT and MRI interpretation. Third, as is displayed on your screens, MERC aims to impart simple therapeutic skills which are going to be extremely useful in the community outreach program. It is by inculcating these skills in a logical and in an orderly and in an organized manner that we would be creating these 11th and 12th standard preclinical students, and of course the post 12th standard, the paraclinical students. When we ingrain these skills into them, that is when they can go confidently and go for the community outreach program. So, simple therapeutic skills, it is there on your screen. Treatment of scalp infections, right from recognition of common dermatological conditions in the community, from there onwards up to the foot, dressing of diabetic ulcers, treatment of diabetic ulcers, etc. These skills would be inculcated into the students. Needless to say that these skills that the students would develop would be strictly under supervision of their medical, surgical and orthopedic teaching faculty, and they would be used them only under direct supervision and guidance from the consultants. An important critical question, how does MERC aim to bring in uniformity of teaching all across the nation with respect to clinical knowledge, especially as it has already been acknowledged in the previous section that non-uniform patient inflow is a major factor responsible for inequality of education even in the setting of hospital-based medical colleges. In order to achieve this, MERC proposes that a list of all the common diseases seen in common day-to-day clinical practice at the primary level has to be prepared. And once this is done, standard history taking, accurate physical examination techniques, analysis, diagnosis, differential diagnosis, anticipated course and complications of the disease with relevant investigations have to be constructed in the format of seminars and standard case presentation. These must be made available free of cost to every student across the nation through the educational portals, that is through the internet. These presentations have to be so standardized, that is, they have to be prepared by experienced senior faculty all over the nation, for whom we have no dearth at all, that every student who masters these art of presentation will automatically possess the minimal required clinical skill towards case solving with reasonable confidence. And of course, needless to say, pass the exams also with reasonable confidence, which is an inseparable part of every student's academic journey. So, with this, we now come to the segment on CORP, or the Community Outreach Program, which can be a village community outreach program, a rural community outreach, or a semi-urban, suburban, whatever. It will be an outreach program. MERC, with its 2+2 years of strong preclinical and paraclinical foundation, clinical skills, history taking, physical examination, therapeutic skills, medical skills, the art of interpretation of laboratory investigations, with all these having been ingrained into the students for 2+2 years, MERC hopes and envisions and is very strongly positive that such a curriculum would make our 11th and 12th standards and the 2-year paraclinical students post-12th standard as an extremely strong working force, as a first-line force in the community outreach program, wherein, along with the knowledge that they have accrued, which they have been taught, along with that, under direct supervision of their internal medicine consultants and their community medicine consultants, the students of 11th and 12th standard and the paramedical and the paraclinical science students, they would, MERC is highly confident that this curriculum will bring about students who will play a dynamic role, an active role in executing the community outreach program. So this being the case, what would be the what are the key summary statements, strategies involved in CORP? There is a placard that I request the viewers to see. Every college will commission a CORP vehicle, a community outreach program vehicle. This vehicle will be equipped with a wide range of equipment and basic medicines for the treatment of common diseases seen in the community. It will also possess basic clinical diagnostic laboratory and sample collection and therapeutic equipment. Every program will be manned and managed and accompanied by a community medicine or an internal medicine post-MD qualified consultant. If there are 150 students in a class, 10 students per day would form a group and will attend the CORP service program. Therefore, every student would have 2 days in a month dedicated to CORP on an individual basis, and a designated community would be visited on a daily basis by the college that has adopted it. So, we are now going to have a summary that is displayed in front of you. 2-year clinical and 2-year paraclinical, the integrated course. What would be the physical structure? It is there on your screens. Physical building and infrastructure would consist of classrooms, laboratories, library, lecture, demo halls, patient examination cubicles, and a community outreach program vehicle. Teaching faculty, professors, associate professors, assistant professors, lecturers, and tutors. CBME program coordinator, mandatory. An in-house internal medicine consultant, on-call teaching faculty, surgery, orthopedics, OBG, etc.